have it on our blog a little bit later. Hold on, let me just make sure. Yes, okay. Recording in progress. Okay, so we do this every year. I'm very we're definitely going to go through all of the different facets of our emergency medicine residency training program. We will have some time for questions at the end, but at any point throughout the presentation, just raise your hand. And if you're more bold, it's perfectly fine to unmute and just ask a question, or you can save them to the end, whatever floats your boat. Okay, so let's get started. I think just in the very beginning, I want this to be more of a dialogue, but I do have a few slides that I'd like to share. So I'm going to share screen. Hold on. So, of course, I have people texting me. What's the link? What's the link for the webinar? Hold on one second. Let me just send that to somebody. I apologize. Okay. So I'm going to share my screen. This is my presentation from last year. I apologize. I did not necessarily update it for this year, but a lot of the information is essentially the same. And I'm just going to present right there. Present mode, present. Okay. So let's talk about the emergency medicine residency here at New York Presbyterian Queens. We are a 3-year residency. And first and foremost, in the heart of Queens, New York City. And first and foremost, you want to come here because you want to join this amazing family. We started here in 2000, and that's exactly what we are here. We are a very, very tight-knit family that also happens to be a residency and a training program in emergency medicine. We started the program in 2004, and our first class graduated in 2007. So we've been around for about 20 years. We've graduated, about 18, 19 classes. So over the years, we have graduated about 190 residents that have gone on to be amazing ER doctors stationed throughout the nation, as well as the world. We have residents even as far as Singapore and Africa and China. So our alumni network is actually quite extensive. We've been building it since 2004. So by no means are we a new program. We've been around for quite some time. And these are just some of our residents from, 2 decades ago, and then a decade ago. And then we have, NYPQ now. Which is a little bit more current. Sorry for the interns and for the interns who might be here. I didn't necessarily update the slides, so I don't have pictures from your class, but this is essentially our family currently. And so, yeah, a little bit of history about our hospital. We were initially Booth Memorial Hospital, which opened here in 1957. And at that time, it actually started out as a Salvation Army home for battered women and children that then turned into a hospital in 1957. We became then New York Hospital of Queens in 1993. And then we became NYPQ. We became part of the New York Presbyterian system in 2015. We are a 3-year residency program that was accredited in 2002 with the first match in 2004, as I mentioned, and the first inaugural class in 2007. So we've had 18 graduating classes at this point with over 200 residents and fellows and a very extensive alumni network. We are a Level 1 trauma center. As I mentioned, we're part of the New York Presbyterian healthcare system, which has been rated in the top 10 for years multiple years in a row. We're a Level 1 trauma center. We are a semi-receiving center with a 24/7 cath lab. We are a comprehensive stroke and thrombectomy center as well. We are a tertiary teaching hospital with full ancillary services. So this is not the hospital where you are putting in all your IVs and drawing all your blood work. We have great ancillary services that makes your job 1,000 times easier so that you who study to be a doctor can be a doctor. We are also the receiving hospital for many local venues. We get lots of patients from Citi Field, the US Open, which is ongoing, and LaGuardia Airport, but sometimes even JFK. So we have a very international community. We also have, and Dr. Sharma is going to talk about that a little bit later. But the diversity, he's going to talk about the diversity that you see here at Queens. It is impeccable and outstanding, and probably you will not find a more diverse hospital than New York Presbyterian Queens. So why our program? Once again, we are, how do you characterize our program? We are a community hospital, right? A private community hospital with a strong academic affiliation. All of us, all of the staff, all of the attendings at NYPQ are Weill Cornell appointed. So we all have either clinical instructors, assistant or associate professors. Some of us are working up to the professor level, but we are all we are affiliated with Weill Cornell. We have access to their portions of their database in their library, and we are all Cornell appointed. We are the only primary EM residency program in Queens County, so you are not, our residency is the residency in Queens. You are not competing with a lot of, local or nearby hospitals. Now there is Mount Sinai residents that work at Helmhurst, but we are the only primary Queens-based EM residency program. We're generally a single site center, other than some rotation that you do at Brookdale, and another rotation that you do with the Fire Department of New York, and also NYU Poison Control. All of your rotations are here at this hospital, okay? So that makes it very easy. You know when you wake up where exactly you need to report. Generally a single site center, okay? We are fully accredited by the ACGME, and we have not had any citations in over 10 years. And again, we are 1-2-3 program, not a 4-year program. And I'll talk about that a little bit more. We have competitive salary and benefits. I will say that our salaries are probably one of the highest. No, not probably. They are one of the highest in New York City. And actually, I apologize, these numbers are actually last year's numbers. So everybody actually got a considerable pay raise. So these numbers are actually much higher. A PGY3 chief now is making about $107,000. A PGY3 is closer to $100,000. Just add basically about $7,000 to all these numbers. The updated numbers are on our blog, so I'll send you to that a little bit later. But we have you get paid really well here, okay? And that definitely has accounted for, the recent uptrend with the cost of living, as well as inflation, et cetera, et cetera. You also have a housing stipend that is built in to your paycheck. So an extra $1,000 is there quarterly for you to use towards housing. And then, so these are kind of your direct, your total direct pays. So again, add about 7,000 to that. So even as an intern, you're about at 90,000. Okay, 97,000, 104,000, and 110,000. Okay, so very competitive salaries. Now we have some other benefits I'll just briefly mention. We talked about the living supplement. You also get $2,000 towards your, for travel to and from work. And the residents will talk about that a little bit later, how they get to and from work. But we have this amazing benefit of Lyft credits, where you get a Lyft account, and essentially every 6 months you get another $1,000. So $2,000 in Lyft credits are applied to that account, so you can go back and forth to various sites and to and from work. There's also meal credits, so you get this $180 a month that you apply towards your badge, your meal card, essentially, and that adds up to about $21.60 per year in food. And then all of your licensure and academic submissions to conferences and things like that, we'll talk about a little bit later. That's another added benefit. And of course, we have great medical and medical dental insurance as well. So let's see. Now, this is now on to, we are now on to, it's 7:42. So, Manish Sharma is he here? Let's see.
I'm right next to you on the screen.
Oh, okay.
What's up? You don't want to talk about didactics? You want to skip to me?
Yes, because you're up next. So you're going to talk about Queens and the patient population and all of the above. Metrics, how our ER runs, etc.
Sure. So when I came to New York Presbyterian Queens in 2008, we were an approximately 80,000 volume ED. Then we had two neighboring EDs, and it was New York Hospital Queens at the time, even though everyone still called the Booth Memorial. My first time in this hospital was when I was 11 years old with my father admitted to Booth Memorial Hospital. I grew up in Queens for a lot of my life. It grew very quickly to 110,000 when two neighboring hospitals, I don't know if anyone's heard of them, St. John's and Mary Immaculate closed, and 30,000 more patients started coming through our doors. It built to 127,000 visits. So it was ranked the 9th busiest emergency department in the entire United States by Becker's Health. This was on 2018, and then we know what happened with the pandemic. And our volume went down during the pandemic to the lowest about 80,000, but it's now back to about 108,000. Why not 126? One thing Sawmill will probably mention later is you get some telehealth experience in this residency through Weill Cornell, where they teach you how to have what do they call it? A webside manner, not just a bedside manner, of how to interact with patients through a screen as opposed to face-to-face, or what we call mask-to-mask now. And a lot of patients have just self-selected out, and the majority of that is peds and fast track. But the critical experience has not changed. We used to see about 340 patients a day. We see about 285. 45 of those patients are not coming, are kids and fast track patients. So we see the same 175 to 180 patients in the main ER, and you end up admitting about 35 to 40% of them. So 1/3 of every patient you see for the majority of your shifts, and Sama will tell you, where you work and how much you work, and he will emphasize that while you work in our fast track area on select days, we are not training city MD doctors. We are training emergency medicine physicians who may 20 years from now want to be city MD doctors. And the bread and butter of it is the main ED and the pediatric ED. And people will talk about it. So we admit an overall of 22% of our patients, but 1/3 of our main ED patients. And when you work those resuscitation shifts, which is called the red team, you're admitting about 75% of your patients. So it's really high acuity. I would say we consult MICU or CCU or SICU or neuro ICU on probably about 6 to 7 times a day. And at least half of those patients end up in those units. Dave Simon, our critical care leader, will tell you we resuscitate people so well in the ER that sometimes by the time they're seen by the ICU, they don't need the ICU anymore. So we are not, I don't believe in bring the ICU to the ER. I just believe in the first 5 hours, you take care of the patient like an ICU patient, and they may not need it. The other part of our ED that's very important that you should know is, and you know this, the population is aging, and it's aging like nowhere else like it is in Queens. So a lot of your patients are critical care, but we put them on palliative care. So we have a very interactive palliative care group. We have a criteria where we consult them, and Dave is also a leader for that because it's the same subset of patients, the critically ill patients who need critical care or need palliative care. Our population, immigrant. I started in Queens. A lot of people start in Queens and then they move out, but a lot of people stay in Queens. 1/3 Hispanic Latino, 1/3 Asian descent, and 1/3 everything else you can think of. Spanish, Mandarin, Cantonese, Korean, Armenian, Hindi, Urdu, Russian, you name it. Your job isn't to figure out if your patient needs translation, because half your patients will need translation. You'll know it's which language. And yes, it'll be the first, the top six most of the time, but many times it'll be a language where you won't be able to figure it out and it'll take a little time to figure it out. We have tons of video interpretation devices. You have the Pacific interpreters on your phone. I like the interpretation devices because the voice is a little bit louder on it, considering a PAC-DD, your phone doesn't always work as well as you would like there. And then we have lots of staff who communicate with patients that they don't really translate for you, but you get a lot of the history from other people who have spoken to the patient in their native language with the patient. The ED is, I will just say, constantly packed. When you come to work, you work hard. And the hallmark of this ED, the reason why a lot of the people who are on this Zoom who work with me will tell you why they stay here. It's because the patients are unbelievably nice. You will never in New York City find a patient population that is so needing your help that is not entitled, not angry. So I'm not going to say every patient will be like that, but if you typically have rotated an ED, you know that 25 to 30% of your patients will just not either want your help, be contradictory, or be just angry at you. I would say that's about 10% of our patients, if that. We keep a track of employee harm and keep safe, which means how many times you have to call security after patients. It's minuscule compared to other institutions. And lastly, it's a sick population that does not have tremendous follow-up, where we have a navigator program specifically designed for those without a PMD, without well-connected insurance that we refer to. We refer 40 to 50 patients every single day to a navigator program that doesn't just, pick up a phone when the patient calls them, they call the patients. It's a foundation through the Robertses throughout NYP, never used in any site as much as ours, where we've actually taken navigators from other sites like Cornell and Brooklyn Methodist because we use it so much. And we refer patients to it. They call the patient, usually within 1 day, and then they call the patient 24 hours before the appointment to make sure they're going to make it. And part of it is community healthcare workers, where they screen these patients to see if they have other needs, housing, travel, assistance at home. So we do a lot of community health and public health within our ED. And most of the people who come here fully understand, number one, you don't tolerate other cultures. You don't tolerate other languages. You welcome it. People who work here love to take care of people who can't even share with most people what's wrong with them. And that's the culture we built here, a very welcoming culture to unbelievably nice patients. And the majority of our staff, non-physician, live around the hospital. So they're the same population as your patients. Welcoming, helpful, thankful. Somal, anything else you want me to touch on?
No, I mean, I think you summed it up pretty well. I mean, just to summarize, highly diverse. It's diversity on steroids. I have never been, I mean, the place that I trained at even before this, I thought that was probably the most diverse part of Brooklyn, and you couldn't get more diverse than that. And then I came to Queens, and it was a diversity on a different level. I always just, when I think of Queens County, I just think of the entire world just crammed into one county, and pretty much the whole world is represented. So you will get to learn that, diseases and disease over a multicultural spectrum. And that is what makes this place outstanding and makes it different than all the rest.
Just one thing I want to add.
Yeah.
You'll realize that the majority of the people here have one thing in common. They are extremely nice. So if you apply here, if you interview here, if you attend my chair session with all the applicants, you'll realize we can make you smarter, we can make you faster, we can fix almost everything about you except what your parents didn't do right, which is if you're not a nice person, you will not fit in here. You will be sorely, highlighted as the doctor that no one wants to be around. So if your parents aren't proud of you, please don't apply to us.
Yes. Bluntly, yes. So yeah, I mean, 6 core competencies, right, that ACGME teaches us, that we have to teach our residents, and 2 of them, which are professionalism and interpersonal communication skills. Those are what I call the parental milestones. Those are the milestones that I hope that your parents have already instilled in you: how to be nice, how to play well in the sandbox. Very, very hard for us to teach that. So please come to your training program with that already mastered. Okay, well, thank you, Dr. Sharma. So we have, we have a little bit of an agenda. Our next on our agenda was Anita Louie to talk about didactics. However, she is also working a clinical shift, and she said she was going to try to make it, but I don't see her here. So I'm just going to go ahead and talk about our wonderful conference that we have every Wednesday, our didactic experience. So one of the first things I should say is it is very unique in that it is highly, highly interactive and highly kinesthetic, meaning we immerse ourselves in the experience, because I truly believe that the best way to learn emergency medicine is by doing just that. Simulation, small groups, flipped classroom, right? When I first got here about in 2012, conference was very, very different. It was that traditional learning where you are kind of just put into a auditorium and somebody lectures at you for an hour at a time with a very, very dry, boring PowerPoint. That was 2012. It is now 2024, and we have evolved our conference into the beast that it is. Okay, and it is quite impressive. You can even go on our blog and you can click on the conference schedule and kind of see what we do. One thing you'll notice there is that every single week our residents are in the sim lab. Okay, pretty much I want to say 90% of our Wednesday conferences have some form of simulation component. Simulation is huge here in our residency, and it is the way we learn. We learn through a lot of simulation. um Sorry, there's an echo. Okay. We built a brand new simulation lab that opened up in May of 2023. It's amazing. I hope some of you have already seen it, and some of you have been students here or are students here currently. But it's an amazing space that is highly coveted. Everybody in the hospital wants a piece of the sim lab. So we believe once again in highly interactive, immersive conference experience. In addition to that, we're the fun residency, and we do a lot of gamification. Okay, and when I say we do gamification, I am and it's not even gamification on steroids, it's gamification on crack cocaine. All right, so it's like we do okay, so we do this 4-part Olympic series, which is amazing, where we do academic Olympics called Smart Olympics. We do simulation Olympics called Sim Olympics. We do ultrasound Olympics called Sono Olympics, and we do pediatric Olympics, which is Small Olympics. Super creative, and it's just a lot of fun. And we combine activities and games and sometimes even athletic activities that are incorporated into learning, because we feel here, if you don't make learning fun, nobody's going to learn, right? You guys are, not my generation, which is Gen X. You guys are millennials, and maybe even the one after that. What's that? Gen Z. And the way you learn is by having fun, right? Having fun and immersing yourself in the experience. We also do EM Cranium. We've done escape rooms. I think we've done at least 3 or 4 different themed escape rooms. We have 3 APDs, right? ACGME says that you need to have 1 APD, okay, for basically 1 PD and 1 APD for a residency of about 30 people. And we are blessed here because we have like 2.5 APDs. Okay, so we have an amazing educational core faculty that really puts a lot of time and effort into the Olympics, the gamification things such as escape the room and this and that. So we also have, of course, we have our traditional learning as well. So we like to pride ourselves in mixing it up, so it's not the same thing every single week. We also believe in short little lightning rounds and lightning lectures where the lecture is only like 15 to 20 minutes, because right? We're all emergency medicine, and we can all agree that we don't all have the best, or most of us don't have the best attention span. So conference is really, really optimized for the new age learner and emergency medicine residents. So that's what I can say. We also have, interdepartmental conferences with the with medicine and surgery. For example, we have a trauma conference that happens once a month where we discuss a trauma case with the surgeons in the trauma department. We also do EDCC, which is a critical care a joint conference with our ICU colleagues. We have palliative come and talk to us. We have other departments come and give us lectures. We have a great grand round series, not only just general grand rounds, but also critical care grand rounds. We had a great speaker today come to talk to us about anticoagulation reversal. So you name it, we do it. We also participate in a lot of the New York City group conferences such as All NYC. There's a New York ACEP that throws 2 conferences a year, All NYC 2 conferences a year, et cetera, et cetera. So that is what I can say off the top of my head. I'm sure I'm missing stuff because conference is so vast and extensive. But that is our conference in a nutshell. In addition to that, I must also say we do foundations. So foundations is kind of your core curriculum. Many emergency departments or residencies use foundations. It's a great curriculum that's also it's modality, so it's modular based. So they give you a case, and then that case leads into discussion with discussion points. It's a flipped classroom model where we give you lots of information beforehand to prepare for the session, including a little mini quiz on Rosh review. And so you come to the session already kind of having done your homework so that you are ready for the discussion. We understand that there are many different types of learners out there. There are people who are video learners. So there's videos for you to watch if that's the way you learn. There are podcasts for you to listen to if you're an audio learner. There are just chapters in Tintinalley if you're that traditional learner that's reading and writing. So there's various modalities for you to learn while you're preparing for foundations. Nao, I'm going to put you on the spot. Did I forget anything?
No, I think you did like an excellent job. Hi, everyone. I'm Nao. I used to be one of the senior APDs. I just pivoted kind of in my career trajectory earlier this year to usher in the next group of APDs who are amazing. I still am at the program. I'm super proud of conference and didactics here. I won't take up too much time because you guys this time is valuable for you to learn about the program, but I will say that I'm just like super proud. I've been told by a lot of people that our didactics here are really top notch because I think they're fun. They're engaging. We try to laugh through it. We like celebrate each other. We learn how to do public speaking. I think it kind of like makes everyone super nervous to get in front of the room, but with everyone's support, it's actually something that you can learn to be proud of. And the attendings at conference are there because they want to be, not because they're forced to be. And I think we have a good time with it. We're also very open to feedback. So if ever the residents, I think they're pretty comfortable coming to us and telling us what's successful and what's not in real time. And if they're ever like, I really liked this versus I didn't like this, we really try to listen. That's my 2 cents about it. Thanks for being here, everyone.
Thank you, Nao. Thank you. And one additional thing I forgot is that our asynchronous learning program, right? So we have a good program here where you are able to learn independently on your own. That's called asynchronous learning. And that's essentially the big component of that is Rosh Review. We will buy that database of questions. For those of you who don't know it, it's an excellent database. It is probably the best one out there that most EM residencies use. It's completely paid for by the department. It's not out of your pocket. And throughout the year, we use it not just with, as a supplement to the foundations, but we we assign chunks of questions that are due, every 2 or 3 months, so we can, so you are essentially preparing for the in-service all year long. We also have other components to the asynchronous learning program. Sometimes that can be peer, like Peer 9. We've done Hippo before. We've done other, we've done EM Coach. We've done other, test bank questions, test question banks. But primarily it is Rosh Review, which will be paid for. So at this point, I think we're running a little behind, but that's okay. Tim, you want to talk about scholarly activity, away conferences, stipends, all of the above?
Sure. I'm Tim. I'm the research director. I used to be the medical education fellow here, and I stayed on for fun stuff for conference mostly, but I do the research things now. And we have a small but mighty research department. We use something I guess is kind of proprietary, like the research and scholarly activity system. Like we basically get points for any of the scholarly activity that you produce. And then if you get 100 points by the time you graduate, you've fulfilled your like required GME requirement for that you have to do for when you graduate. So anything that you do, teaching students, making blog posts, going presenting a poster, going to a conference, all these things count for different numbers of like RSA points. And then once you collect enough of them, you're able to graduate. And that's how we make sure that it's not only just like making papers and things like that count for scholarly activity, but we want you to get involved with any of the type of education or research that's out there. We also and because we're tracking your points, it's very, very individualized. We spend we take a lot of time and attention to make sure that everybody is learning the things and developing themselves as like a lifelong learner for the future. And then my goal as research director is also to try to get you to as many conferences as possible, basically, because you get money from GME. I think it's $1,000, right? If you go and present a poster.
Correct. Every scholarly activity that you present, and again, there has to be a verbal component. So if you just have a non-moderated poster, it doesn't necessarily, it's not funded. But if there is a verbal component to your research and scholarly activity, they will pay up to $1,000. Sometimes that can be stretched to about $1,200, especially if it's far away and it's more costly. But $1,000 to about $1,200 is what GME will pay for you to present your scholarly activity. And Tim, just to kind of supplement what Tim was saying, I'm going to make this even smaller. You can see every resident has this what they call an RSA sheet, research and scholarly activity sheet, where you chronicle and catalog all of your scholarly activity. And it's, more than just traditional research. You see down here, it's like sim stuff, like sim wars, it's newspaper articles, it's sim cases, it's lectures you give med students and interns, it's blog posts, it's social media, it's global health, community outreach, representative and scholarly and representative and volunteer work. So all of the above.
And all of the interns get to go to New York ASAP together. All of the second years go to SAEM together, and all of the third years go to ASAP together. So that's paid for by the residency. So that's
right.
A good bonding time, but also a good time to experience going to conferences and things like that.
Yeah, and I think that's also super unique to our residency training program. I don't know of a single other residency where you are going to a conference and you are funded to go to a conference every single year, despite your scholarly activity or not. So for interns, it's great because it's their first month. Their first month is a little deceiving, I want to say, because it's a full orientation month. It's a lot of lectures and workshops, and then you go to New York ASAP in Lake George, so that's a nice little vacation. And it's like, people come start residency and there's this wonderful month in the beginning and they're like, this is residency, sign me up. And then block 2 starts. And then the real work starts. So, but all of our interns go to New York ASAP, and then our second years now go to SAM, which is a highly academic conference in May. And then, when you're a senior, you have to get a job, you have to get a fellowship. So everybody goes to ASAP. And again, I think that's very, very unique to our program. Since Tim is also speaking about stipends, I'm also just going to add, and we're going to talk about this again when we do global health. but we have actually recently increased our stipend that is available to residents for global health opportunities. So that used to be 3,000. I haven't even made this announcement to the residents yet, but that is now 4,500. So we basically will offer $4,500 for residents to go abroad and do great global health work, up to 4 weeks of that. So there is that allowance as well. So there's definitely funds and means for you to do some really, really great work here, yeah, outside the shop. And then, we have something called the research tracker as well, which really tracks how much we're doing, like so at any given point, a resident can sign on and say, hey, these are the projects that are going on. These are the projects that I want to get involved with. We have research meetings every month that are departmental. So we all have academics first, then we'll have ultrasound, then we'll have sim once, and that way residents are able, especially residents who are not on projects, are able to come and see what's going on and sign up for projects. So scholarly activity goes a long way here. And if you're worried about the RSA points, getting 100 points nobody has ever struggled to get that. Everybody gets there. But it's a great way for us to keep track of what you're doing. It's a great way for you to kind of have this, catalog of what you've done is essentially, very easy for you to put your CV together come your 3rd year because you have it all tracked. Okay, so that is that. Is Joanne here?
Yeah, I'm
Joanne?
here. Can you hear me?
Yes, we can. Take it away, Joanne.
Hi, I am Joanne. I'm the director of the resident ultrasound education, and I'm going to tell you a little bit about all the ultrasounding we do here. So you do a total of 2 months during your 3 years of residency. You do one 4-week block in your intern year and a 4-week block in your PGY2 year. And then basically the layout of this rotation is you go to tape review every Friday, where you just go through all the scans for the previous week. You talk about them, you learn. And then 3 times a week, you do dedicated scan shifts, usually like 9 to 5. On these scan shifts, you are going to get one-on-one time with an ultrasound faculty, usually joined by the fellow for about 5 times a month. And the goal on these scan shifts is for you to ideally get like 20 scans per shift, with a focus though on really educational, interesting, or helpful ultrasounds. So something that we have the privilege of doing here is nerve blocks. So honestly, any kind of block you can think of, we typically are able to do. And then even TEE or transesophageal echo, we just started doing that last year, which is really cool to use in resuscitation. So those are some really fun things that you'll be able to do usually on your scan shift when you have extra time to focus on ultrasound and the education portion of it off of a clinical shift. So we are available usually to do these extra types of advanced ultrasounds if someone's working clinically and they're like, hey, I have someone with a hip fracture. I don't have time to set up for a nerve block. Can you guys do it? That's like the perfect use of the ultrasound team. And then you will, I feel like, typically get to do a couple by the end by the end of the time, by the end of your rotation, or at least by the end of residency. If you are ultrasound bound, we have an ultrasound scholarly track that kind of just gets you more involved in the research projects that we have in our department, gets you involved in our journal club, and then you'll get some mentoring on the entire fellowship application process. On that note, we do have an ultrasound fellowship. We currently have 1 fellow right now. I kind of like it because where I did my fellowship, there were 3 fellows, but with just 1 fellow, you get to just focus all of your time on this educating the single fellow. And I feel like the fellowship is kind of whatever he wants to get out of it. And so whatever interest he personally has, we're happy to help support. And whatever projects he wants to spearhead, I feel like, like all of us are there to help him achieve those. So overall, I feel like this residency does a lot of ultrasounding. I was very pleasantly surprised. I just started here last year from another program where ultrasound was also very strong, but I was just blown away by the amount of times like the residents will go get the ultrasound off of a scan shift, just like on a clinical shift, and the ultrasounding on their own, which is really exciting for me to see. So overall, at this program, I feel like the culture is, even though we have ultrasound available like in-house, ultrasound techs, people take the initiative, residents attending the like, to do these bedside ultrasounds, to like learn how to do advanced ultrasound, like critical care ultrasounds, and just incorporate that into their regular practice, which is really exciting. What else?
How many machines and what types and where do we keep them?
Oh yes, we have so many machines here. So they're all honest to me, in great quality. They're all really nice. They're the fancy TEXs, which are how I remember the giant touchscreen ones that could swivel to the side. We just got a brand new one last month. So we have 7 total machines now spread throughout our main ED, our PVD, and our fast track area. We kind of keep them pretty spread out throughout the ED, so they're readily available no matter where you're working. They're pretty well maintained. Yeah. We have 5 total ultrasound faculty right now in our department, plus 1 fellow. So it's a pretty great group. Everyone is super invested, and it gives us enough people so that we're always able to accompany you guys on your scan shifts during these rotations. Am I leaving anything out?
No, well, I will take a moment, actually. I'm going to share my screen and just show you, for example, like this is our blog, and like down here is our kind of our educational section. You have this whole section on medical education, which we'll talk about later, but you have this whole section on ultrasound, and these happen to be, our older posts, but now most of our ultrasound posts are all here in ultrasound case of the week. And as you can see, these are the more, ones from 2024. But every single resident will do one of these blog posts during their rotation. So it essentially leads to this wonderful resource where, you want to learn about an erector spinae nerve block. You'll just go to the blog and you'll figure out how to do that very quickly. So it's, become quite extensive since, we started the blog in 2019, but there's just a plethora of information here at your fingertips regarding ultrasound as well. But yeah, I think that, so our residents graduate with an average of 650 scans. So, and that is, in order to graduate here, you need 400. Our average is 650, and 400 is way above the national average and what is mandated by ACEP and ABEM. So you will learn ultrasound here, and even more importantly, you'll learn critical care ultrasound, because when you are in the trauma room, every single trauma patient is getting a FAST. Everybody that's short of breath or have chest pain is getting a cardiac and lung exam. So you get really, really good at critical care ultrasound, which I think is super, super important. All right, and there's an ultrasound WhatsApp chat. We actually have a WhatsApp chat for EKGs and EKG learning. We also have a WhatsApp chat for radiology, and then there's a WhatsApp chat for ultrasound. There's a WhatsApp chat for critical care, and you can join any of these WhatsApp chats to learn even more on top of all the stuff that we teach you. Joanne brought up tracks, so I'll bring that up very, very quickly as well. Tracks are these amazing things. They're essentially like interest groups, right? So you, at the very beginning of the year, you choose what track you want to participate in. And it's very low key in the sense that it's not designed to be stressful. It's designed for you to explore various interests within emergency medicine. So we have 7 tracks here. We have academics and education, we have ultrasound, we have simulation, we have global health and community outreach, we have administration, we have pediatrics, we have critical care. I think We also, and tracks kind of are morphed from interest in general. So right now we have 2 residents who are really interested in toxicology. So we should actually talk about maybe creating a toxicology track. At one point we had a lot of people who wanted to do EMS. We had an EMS track. So tracks are really kind of spawned from kind of the current interest level in the training program. So, let's see. Now, we are going to move to Dave Simon, who's going to talk about critical care.
All right. Hey, everyone. My name is Dave. I'm one of the assistant PDs here at Queens. Along with everyone here, I actually get to do what I help shape this residency. I found Queens when I rotated here in a sub-I, and I actually fell in love with it. Just a quick about myself. I did residency here. I completed a simulation fellowship and one of the APDs. I'm going to briefly talk, because I know we're behind, about some of the critical care opportunities you'll have as a resident at New York Presbyterian Queens. In Queens, the shifts, we have our main shifts, and then we have our resus shifts. They're in our red shifts. That's what they're called. Each resident will approximately have 1 to 3 shifts of these a month that will cover the trauma room and our little mini ICU room that's called the CEU. Here, we manage the STEMIs, the stroke activations, the cardiac arrests, the respiratory distress, traumas, anything that has patients that might be decompensating, any unstable vital signs, they go to these areas. So you start these shifts as a second year, but what's really special is during an intern year, we give shadow shifts, 1 a month to each of the interns. And this really allows them to just experience and learn everything there is about these really, really sick patients. They're an additional member to the team, so they have the freedom of learning without the pressure of being the sole provider. So they can just go in there and take care of these sick patients, right? There's no stress of writing the notes. That's not their responsibility. They could just embrace the education and ask the questions when they can. It's the residents' favorite shift. Yeah, I know it was definitely mine. I loved it. On top of that, we actually incorporated a critical care curriculum that we start with the interns, and that's held during the ultrasound block, because ultrasound and critical care go so hand in hand, just like they were talking about. What this curriculum entails is one-on-one simulation and lectures going over the fundamentals of resuscitation. It's designed to be very clinical oriented. The residents are allowed to practice what they learned in lecture with the hands-on simulation, and then carry it out to the bedside during their shadow shifts. Just a quick what it's about, right? It's a combination of physiology and an evidence-based medicine. Some of the topics we discuss, we go over shock, uses of various pressors, physiologic difficult airways, making sure that you're comfortable with BiPAP and vent management, and then cardiac arrest going beyond ACLS and incorporating what Dr. Sharma said, palliative care discussions as well, because that is so crucial. We have a really good rapport with palliative here at Queens. We got such positive feedback during this rotation that we actually made a advanced curriculum for PGY2s. And this is actually run by our medical education fellow, Dr. Brian Smith. Normally, when you think of emergency medicine, what you think of is these really sick patients, all the crazy traumas. That's not always the case, but it's what brought a lot of us into emergency medicine. So we wanted to make sure that you're prepared to learn how to manage any type of critical patient that you can come across, because Queens has so much to offer. I don't know if I missed anything, but let me know.
I do want to add something. So yes, critical care is what keeps you going. It's not all your patients.
No.
But I do want to add that if I would share our quality dashboard, so we track a lot of things, but specifically we focus on the sickest patients. And in general, not always, there are many patients who don't fall into these buckets, but trauma, sepsis, stroke, STEMI are 4 specific groups. And there is nobody in New York City or NYP that can match how good we are at those four things. And that's all contributes to our adjusted mortality, which is why we were a 5-star CMS hospital, because everyone understood in the hospital that all of these patients are coming through the ED and they're getting unbelievable care. So by the time they reach an inpatient setting, whether it be a floor because they've been fixed to a great extent, or to a ICU, all of that started in our ED.
Yeah. Okay. I second everything that they said. I'll just add that I have alumni constantly text me and talk to me and call me even, and they say, you know, people, new grads struggle with taking care of sick patients in the shops that they go on to, the EDs that they go on to. And for our residents, it's no big deal because they know how to take care of the sickest of the sick. So you will get really, really good at taking care of sick patients, the sickest of the sick here at Queens, just because of our acuity in general, plus that matched with great critical care curriculum and didactics. Don't fear, you will learn how to take care of sick patients.
Sorry, is Rich in here or not on this?
I don't see him.
Okay.
Don't see him.
Oh, yeah, because his term, which I really love, is protocolized medicine. So we don't protocolize everything you do, but for the sickest patients, it's been shown over and over again that if you have a pathway of how to take care of these patients, they always have better outcomes. So something that your future bosses after leaving residency will want to know is, do you follow protocols? And that's part of your training in how to systems-based practice. I know you talked about it, Samuel, but you can expand on that.
Yes, so systems-based practice is without getting into all the details, it's basically your hospital system and how they practice, right? And what flies and what you do at one hospital, maybe a hospital system may be very different than another hospital system. So, but that is what we teach you here, is what is going on, right? So learning that your ED encounter is all but a small microcosm of the big picture. What happens when they get admitted upstairs? What happens at the quality meetings? What happens at the enterprise level? What happens at the hospital? At the bigger level. So that's all part of systems-based practice, and we do have some protocols for many things, but at the end of the day, we teach you how to develop a great spidey sense, right? Which is to be able to recognize who is sick, who is not sick, and then be able to manage a very, very critically ill patient to the best of your ability. Okay, I think I'm going to go out of order a little bit, only because I see Sabina. Sabina, are you here? I see you here, but I know she's working. So she's also.
Hey, yes, I am here. One second, let me turn my camera on.
So maybe we'll just jump ahead to you, because I know your section was actually
Thank
not jump
you.
ahead, but let's just skip a few things, and then why don't you take a couple minutes to talk about global health and community outreach?
Sounds good. Hi guys, I'm Sabina. I just joined. I'm like one of the newest attendings in NYP Queens family. I just started here about a month ago, and I joined from Columbia, where I did my fellowship in global health, and I got my MPH there as well. I'm really jazzed to talk to you guys about the global health and community outreach opportunities for you. I think that this is like honestly more than I've seen at probably any other hospital, which was one of the reasons I was so inclined to come and join this hospital. I'm not sure exactly how much Samuel jumped into a lot of this, but I think what really sets this program apart from most other residency programs are two things. One is it's really, really hard to find like an excellent, high quality 3-year residency program that's going to give you a full month of elective opportunity. And the way that it's been kind of structured is that you can kind of do 2 weeks plus 2 weeks, or if you have something really, really incredible, there's possibilities for you to do 4 weeks all at once, like in continuum. And you can spend that time pretty much as your heart would desire. And that kind of leads into doing global health work. In the past, residents have gone along with faculty to Norway. They've done simulation experiences and simulation trainings there. In a few weeks, people are going to China. They're going to be doing a bunch of ultrasound work there. Other folks have gone to Peru in the past and done ultrasound work there too. I've done some work like in Africa. I've done work in South Asia too. So hopefully those could be opportunities for residents who are interested. So part number one is to have 4 weeks to be able to do international work is just so unheard of during residency. And I highly, highly recommend taking advantage of that time. And then two, which is like kind of mind blowing to me because this was definitely not there for my residency, is that we have funding available for you too. So not only do we want you and encourage you to go see how medicine is practiced around the world, we can help you financially with that too, and it's quite a generous amount. And I think like one of the things that we really just want you to get out of this experience is that there are healthcare systems that are just vastly different around the world and even in our own country. So if you're like, no, Sabina, Somal, I really, really am interested in doing a domestic project, working on like the Indian Health Services on a reservation or doing just things a little bit more at home, that's completely like embraced, and we're so excited to support you pretty much in whatever your desires are there. From a community outreach perspective, there like this is definitely like a population that is deeply, deeply in need. I'm still learning about this community because I'm new to Queens in the last 5 weeks, but you have folks that pretty much have come from any corner of the world, and that leads to a lot of like just kind of opportunities, I think, for those folks who just kind of have like a passion of social emergency medicine or outreach work. Next week, we're doing some work to build like sexual health awareness among migrant sex workers. So there's cool opportunities with that. Just a huge, sick, underserved population. So there's a lot of opportunities from you from like an academic standpoint, from an elective standpoint. So we welcome you here.
Thank you, Sabina. Yes. Global health kind of obviously took a little hit.
Samuel, can I just say one thing? I totally
Yeah.
forgot in my presentation. I know I talked about the diversity of our population. I do want you to know how underserved our population is. We are pretty much city hospital dynamics. I would say about 82% of your patients you see in the ED are underinsured. That definitely leads to opportunities in how, and when I say underinsured, I also mean under health literate. So there are a ton of opportunities here, very similar to, say Elmhurst Hospital, very near us. It's pretty much the same population in terms of how much resources they have and how much of an impact you can have on their lives.
Yes. What was I going to mention? Oh, I was going to also mention, yes, obviously things downturned during COVID and nobody was traveling anywhere or doing really any global health because there was a worldwide pandemic. But I will say, since 2022, the amount of stuff that we have done in just a short 2 years has been phenomenal. And we do have a lot of, bases now that we can kind of consider, recurrent trips, China being one of them, Norway being another one. Peru and Ecuador are starting to turn into an opportunity that is available to everybody every year. So there's a lot of opportunities for you in global health. We spoke about community outreach also, but it kind of also along the same lines is event medicine. So there's also an opportunity to do event medicine. We have one of our ex-core faculty members who's now stationed in Northwell. He actually does a lot of sports medicine and event medicine. So we frequently will pair our residents up with him. They'll do things like marathon tents. They'll do major like sporting events plus concerts and things like that. So if sports medicine is your thing, there's an opportunity for you to do that as well. So at this point, I'm going to switch it to simulation and wellness. And that is where Anika Niklani, our simulation fellowship director and our wellness champion and beloved core faculty, is going to come in and talk about all of that.
Hi, everyone. Beloved, I love that. Thank you. So my name is Anika Niklani. I am originally from South Florida, but I've been in New York City for the last, I don't know, 10, 12 years now. I did my residency at NYPQ. I also did my fellowship in simulation as a first fellow in our program, and I've stayed on as faculty here. So I wear 2 hats. First is simulation, and then the next is wellness. So I'll talk about both. I'll start off with the simulation first. Like Dr. Parikh had mentioned earlier, we do a lot of simulation. It really is one of the best ways to teach and learn as well. In every conference, Wednesday conferences, because of this flipped classroom style learning and small group learning, simulation, which is hands-on, is going to be in every other week. You'll have it as a small group, and you'll rotate through a simulation. We toggle between a simulation scenario or a procedure. We tend to do a lot of procedures in Queens, given all the information that you got earlier about the high acuity, a lot of resuscitations. It lends itself to a lot of procedures. So the simulation department is in charge of all of your procedural competency practice, meaning procedure days, procedure skills, cadaver labs. So we put that on. Some of the procedures that we practice with our task trainers are central lines. We've done ED, we do thoracostomy tube, we do thoracotomy, cricothyroid, lateral canth, arthrocentesis, LPs. We just got brand new baby LP and adult LP models. So tons and tons of task trainers in our brand new sim lab, which we had talked about before. We just opened up last year. We're fortunate enough to have a very sizable donation to our department to build this brand spanking new sim department that has two like scenario rooms and a control room in between, and it is attached to our NYPQ library, and it is open to the rest of the hospital. So you'll have multidisciplinary employees come in, use the library. It is a digital library, so there's not really a lot of books, but it is a space for education and learning, and there are also two classrooms there. So I know Nao had put up the site for the Quack Talk, and you'll be able to see a lot of the photos on that site. So back to Wednesday didactics there, or sorry, Wednesday sim. In addition, almost every week we have something called afternoon sim, where we'll have a 30-minute case, mostly cases that you'll rotate with your like other residents. So 4 of you will be on for afternoon sim. You'll do 30 minutes of that, and then another 30 minutes of what we call a one-to-one sim, and where one resident is kind of with the educators there, whether it's me and a fellow, and we'll do kind of a case that's really focused on the evaluations that were given after your shift, the shift evaluations. With that said, I should have started this whole thing off, especially with Sim, is that we are not evaluative, we are not punitive. This is not meant to scare or punish or really be like a fishbowl, right? It's more of a learning experience, and to use the simulation scenario to improve and to get the feedback, essentially. So sim is fun. That's our mantra kind of throughout. Never meant to scare you. We're all there is a very, very high priority on keeping you psychologically safe, and we are all trained to debrief appropriately. We have a pretty big group. Off the top of my head, I think we have about 12 of us. Everyone has a different role. A big chunk of the sim team is also part of the academic team as well. So Dr. Simon, Dr. Louis, Dr. Shet, they have all been sim trained, and they all do a lot of sim work with us too. We have like we had mentioned for our tracks include these debriefing courses, as well as journal clubs, which we do once a month, where we talk about different adult learning styles and different debriefing like methods. In addition to all of the like weekly things, we do simulation, like big simulation, I want to say sim events. I don't have a good word for it, but we do sim wars, we do sim Olympics, where we'll have like a full day of like multiple different simulation like education events. And then every year, which we started 3 years ago, and now we've done one every year, we'll have this NYP Enterprise collaborative educational event, usually in the very beginning of the year, centered, and it's like class specific, small groups centered around one major theme. So we've done kind of like a resuscitation or a better ACLS theme. Last year it was more ultrasound focused, and then this past year it was called Little Lifesaver, which was pediatrics and OB emergency focused. So lots of sim here, lots of simulation activities. If you are interested in if you're interested in whether it's teaching, education, or task training development, we have a lot of space and a lot of guidance here. So that's sim. Anything else I missed for simulation?
Well, I will just add that yes, simulation is probably one of our biggest sub-departments within emergency medicine. So many people, we match fellows, and then the fellows end up staying here. So we've, as Dr. Nicolani mentioned, a lot of our APDs are sim trained. So that's why you see a lot of sim in our education, because it's all kind of interspersed all together. The other thing I will say, this is a common question, is how is the ER? What's the reputation of the ER in the hospital? Do the people respect the emergency department? And I got to give it to Sim. I think one of the reasons we are so highly revered and respected in the department is because we teach everybody everything. The Sim department does ACLS for everybody, and ATLS, and PALS, and BLS, and we teach renal fellows how to do renal ultrasounds, and we teach cardiology fellows how to do echoes, and we teach renal fellows how to put Shileys in, et cetera, et cetera. So I think just that in itself, we have great interdepartmental relations with every department. There's not a single department that we don't get along with. And in fact, they love us, they respect us, they know that we work really, really hard. And so I would say a lot of that is because of the sim department. So I wanted to add that. And then of the fellowship, of course, and just to summarize, remember, we have 4 fellowships here. Simulation is one of them. Ultrasound is one of them. Medical education is one of them, which is a 2-year fellowship where you can get a master's. And then there is formerly called the admin fellowship, now called the healthcare leadership and management. No, healthcare management and leadership. Or did I get that wrong? I don't know. But anyway, it's the administration rotation, and that's typically 1 year, or you can do it in 2 years and get a master and an MBA in business and medical business. Sorry. Back to you, Anika. That's what I had to say about sim. I'm sorry I went on a little bit of tangent there with the fellowships, but let's talk about wellness. And
Yes.
before you get into that, I wanted to just put a shout out to all my residents, because it is Wednesday and they all have off, and we have something called Wednesday Wellness, and so many of them are here representing the resident body when they could be out and hanging out with everybody. I know that there is a subset of the residents who are actually right now all together. I see them, Kyle and the EM residents, it's one of our chief residents' birthday, and so they're all at a karaoke place, having a lot of fun, basically. Hopefully they can. Oh, there they are. If you can say hi, Kyle. Say hi, Megan.
Oh my goodness.
Okay, maybe.
Wild. They're
Yeah.
wild.
Hi, hello.
Hi. Okay, everybody say happy birthday, Megan. Megan's there in the background. She's one of our chiefs. Oh, and there's Rosalina. So as you can see, they're all together. We are a family. Wednesday Wellness is great. And now Anika's going to talk about all of that. Sorry.
I'm jealous. I want to be there. Just to piggyback back to like our interdepartmental relationship, it's also with these relationships that we've kind of made with these other departments, very open to collaborating with projects. So we have multiple projects I have this video of them at the karaoke bar in my corner here, so I can see them like dancing. But you can create projects with them. We have multiple projects ongoing right now with the neuro ICU, with the trauma team, with pediatrics, and it's kind of carried on through the years. So this is if you have any interest in doing collaborative work with other departments, this is kind of like your pipeline. Okay. So number 2, I do wellness. We do a lot of wellness here. I think that overall, in terms of the curriculum that we have, it's twofold. It's the structure and the didactics that we have, as well as the fun times that we do that we also enjoy as well. So we created this program to kind of combat burnout and compassion fatigue and build resilience kind of in a world where this has become significantly important to our mental health and and our growth as good healthy physicians. It's a huge part of our training and growing. And it came to light that we needed a little bit more structure and education and knowing, what makes us well. And while hanging out with friends and having community and enjoying ourselves at karaoke or outside with your friends, there's a little bit more in terms of the structure that goes behind it. So what we do for wellness, first and foremost, is we have these structural lectures that we do once a month, sometimes once every 6 weeks. So for example, today we did a lecture on physician suicide awareness. As maybe most of you know, that this is Suicide Awareness Week. And then on September 17th, it's National Physician Suicide Awareness Day. And so that's kind of what sparked the entire ACGME National Wellness Campaign, and making sure that all of our residents, all of our medical students, all of our physicians are healthy and well. So we have these structured lectures. In addition to that, every Wednesday, like Dr. Preet had mentioned, we really protect our Wednesday wellness. We'll do an organized wellness event every month, whether it's a big picnic or barbecue at Gantry Park, or we just did a Mets game the other day, like a Mets outing. We've done axe throwing. We've done, I think that for the Fem-EM night, we've done a paint night. So that's kind of like the fun, decompress, enjoy. Well, I guess the Fem-EM is a little bit different than our wellness events, but the wellness events are really just our fun time to kind of get together, decompress, and be together on our Wednesdays. That is alternates with our well events. Those are usually kind of these group events where we'll sit and talk regarding a topic, whether it's coping strategies with handling the volume and the stressors in the ED, or dealing with difficult consultants. So I'll usually have a topic, and then we'll kind of have like a free for all where everyone takes a turn, kind of speak their mind. It could be topic related. It could just be whatever they want to talk about, and it's a judgment-free time to kind of air our grievances. It's very helpful. It's kind of cathartic to kind of hear the things that are on your mind that you probably want to get off of your back without feeling judged. And so that's like the number one rule. We'll do that every other month. In addition to that, we have kind of organized wellness throughout the year, and where we'll have like wellness events, which includes like our yearly wine trip for graduation in and of itself, our retreat, our yearly retreat where we'll get together and kind of review the residency. And so all of that kind of encompasses wellness, like large wellness events throughout the year. What's built into your kind of day-to-day is are the ideas, the set up wellness buddies that we have. So we'll be paired up with a wellness buddy kind of in your intern year, and they will be carried through your 3 years. If you decide on using another buddy, that's completely fine. Same thing with your mentors, and you can have multiple different mentors. You can have your main mentor who's just kind of there to help guide you through residency. You can have a mentor for your career guidance, and so we'll set you up with a mandatory mentor that you choose, and they will be your mentor whether through the rest of residency. You can also change those as well. What else? You talk about like vouchers, lifts, the lift thing.
Yeah,
We talked about it.
we have great benefits here as well. So yes, I think the fact that you're tired after a shift and you're worried about driving home, you don't have to worry about that because you have your lift tickets. So there's a lot of great benefits. There's, meal cards. We
Yeah.
talked about a lot of that stuff.
I think I would just say in general, systems wide, wellness is super important to the department and to the program on a faculty level as well as for the residents. So one of the biggest changes I think that we've noticed is this shift from all 12 hours to adding in the mixture of these 8-hour shifts amongst your shifts. And that has been proven for better sleep, better coordination of the other things that you have going on in your life. And so that has made a big difference systems wide for the program in terms of resident wellness. What would, I don't think I have much of anything else.
I think you did a great job of really kind of comprehensively describing our wellness program here. And I will tell you, I think it is one to be championed, one to be it's the role. I think our wellness program here is the role model for what other programs aspire to be. We have wellness on so many different levels, from a curriculum to mentorship to Wednesday wellness, to everything. So thank you.
Thank you.
I think we do wellness really well. And it's definitely something that has grown also over many years. One thing that I will add is, we take resident feedback here very seriously. There are multiple avenues and ways for you to give us feedback. And you can give us feedback at any time, because there's constantly these links being sent out where you can leave anonymous feedback for whether it's a rotation or conference or wellness ideas. And, I'm constantly listening to ideas for wellness and curriculum. And we always try to incorporate that into actionable change whenever we can. And every year when we go on this retreat, which Dr. Niklani mentioned, we do go away for an overnight stay somewhere. Last year we essentially went camping in Connecticut, and we review the residency, and during that review, that 4-hour review, we talk about everything, and we go over all the surveys that the residents fill out, and we go over ideas and concepts and things like that. So we take your advice and your feedback very, very seriously in this program. You also have twice a year, you have the opportunity to evaluate all your attendings. We evaluate you, so you have the opportunity to give us feedback about us too, and we take that information also very seriously, and we use that information to help guide attendings who may be struggling to teach in an academic center. So feedback goes both ways.
We stayed in lodges in an adult camp. We didn't go camping. We weren't in tents.
I mean, it was okay. Cabins is still camping, isn't it? I mean, no, it wasn't.
Okay, Sawmill, it was camping. You know my experience there, okay?
I know. So, but look, if you hate camping, don't worry. It's we did that one
No,
year.
we weren't in tents.
We go to the
on
beach.
ground.
Last year we went to the beach in the Jersey, a nice Jersey beach. We have done Bear Mountain several times. One year we did Mohonk Mountain House at the very, very beginning. That was really nice. But yeah, we try to do something different every year. Okay. I now want to switch to Dr. Brady, who's going to talk a little bit about pediatrics, and then we'll have the residents talk, and then it will be Q&A.
Great. Hi, I'm Carrie Brady. I'm the Associate Director of the PZD and also Director of Pediatric EM Education. So we have a separate pediatric emergency department. If you watch the residency video, you'll see it's this beautiful underwater theme. So it's kind of a nice departure from what you see over on the adult side. We do see more than 20,000 kids per year. And ideally, we're seeing ages 0 to 21 in the PZD. Over the course of your 3 years, you'll spend about 20 to 22% of your shifts in peds, and we make it a longitudinal experience. So you're not spending a month in peds and then don't see any pediatric patients for months on end. You, like, every EM block, there will be some pediatric shifts, and that way you kind of like don't miss the seasonality of things. In the PZD, we have 8 PEM certified attendings, and that's a combination of full-time and per diem. Of those, 2 have actually done an ultrasound fellowship, and one of them is double boarded in PEM and EM. So it's like a nice, I think, variety of experience with the different attendings that you work with. We do have a pediatric inpatient floor and a step-down unit, and that is staffed 24/7 with pediatric hospitalists, and the residents there are from Cornell. We have a pretty good relationship with them, and the patients that we do admit, most of them are able to stay here. The ones that need to be transferred oftentimes will go to Cornell. We do have many peds subspecialties available to us, both on site and through Cornell. I'd like to point out, especially feel like in the last year, the PZD department has actually been pretty active in research, and we've especially been doing a lot of things in conjunction with both simulation and ultrasound, and have been doing some fun studies, playing with ballistic gel and coming up with all these various ultrasoundable models for things that are pretty rare in peds, and have actually gotten it accepted and even gotten an award at CORD this last year, which was fun. In terms of the pediatric presence in the Wednesday conferences, everything's divided pretty much into 6-month blocks, and during that time, 3 or 4 of the conferences will be specifically pediatric focused, and there will be at least 2 hours of pediatric education during that conference, and it's usually led by both a PEM attending and an EM resident who are coming up with presentations on various things. There, like we'd mentioned before, one of the interest tracks is pediatrics / pediatric critical care, and we meet 3 to 4 times a year talking about interesting articles, having pediatric procedure labs, and that's pretty much it. Anything to add, Salmo?
No, I mean, thank you for that. I think probably one of the biggest things to know is that, you will get peds experience here. You will know how to take care of not just, bread and butter peds, but also critical care peds. Look, nobody is, everybody gets a little nervous when a sick kid comes in because it's just a kid. And, I think the stakes are higher, but we see our fair share of critically ill patients, and we don't necessarily have a PICU right upstairs. So it is our job to stabilize them to the best of our ability before we transfer them to Cornell. You will know your pediatrics by the time you graduate. All of the alumni say the same thing, that they even if they felt like, okay, I don't know how to take care of a sick kid as well as I should, they all go on to their shops and they say, we're better trained to take care of sick kids than other providers. So it's also longitudinal, which is important. Like I think a lot of other places you'll have a month of pediatric EM and then another month of pediatric EM. But if that's the case, you may very well lose that seasonal variability of illnesses. So like if you're in peds in the summer, it's very different than peds in the winter. And if you're in the summer, you'll miss out on all the respiratory illness of the winter, and vice versa. You might miss out on the traumas in the summer when everybody's out playing in the summer weather. So it is longitudinal, and you end up with about 22% of your shifts are in pediatrics. So 1 out of every 5. So you will be well versed in peds. And we also, just to try to tie simulation into this, right? You don't get pediatric codes every day, and that's a good thing, right? That's a good thing for humanity and our community in general. But if there's something that we don't see every day, we supplement that with simulation, right? So we do a lot of morning reports where we go over critical care peds, and we also do a lot of simulation in the in terms of pediatrics in the sim lab. Okay, thank you for that, Carrie-Ann. Now I'd like to turn it over to Dylan, who is one of our chiefs, and he's going to talk about scheduling and resident life. So take it away, Dylan.
Hello, I'm Dylan. I'm one of the 3 chiefs. Specifically, I do a lot of these scheduling duties. So kind of just to briefly summarize the schedule as best I can. So like that has been mentioned before, we do a mix of 12-hour and 8-hour shifts, which was previously requested by the residents to have kind of work in those 8 hours, so you can do more of your outside EM life around shifts, and everything is very well balanced and tracked. We have a spreadsheet where we're seeing how many pediatric shifts are you doing, how many night shifts are you doing, how many weekends, which holidays are you working, And so that at the end of the 3 years, every resident kind of ends up in the same spot. They get the 20% of their shifts being in pediatrics. Everyone has the same number of weekends, same number of nights. And we have a lot of, everyone goes into EM because of the flexibility. And so I think that our residents, when people have major life events, when things come up, that we are always able to cover for each other. And when that happens, we are still, again, keeping track of the hours, so that everything stays fair and balanced in the end. And yeah, and kind of like what's discussed earlier, we have, you will have 2 weeks of vacation in the first half of the year, 2 weeks of vacation at the second half of the year. And we keep our we take requests for the year, kind of distribute it fairly amongst the residents. What else? Yeah, so Dr. Brink is sharing how many hours are expected. So the shift requirements go down throughout your 3 years, but kind of your on-shift responsibility kind of increases. You're seeing more patients, taking care more of the board. And I think, something that to the chagrin of Dr. Parikh, we're very on top of making the schedule and getting out early and ahead of time, so that you can kind of plan your major life events, vacations, things like that. I know some other programs, like that our residents rotate at, like we still haven't got our schedule yet. It's Thursday and I start on Monday and I have no idea when I'm working. Whereas Parikh is like, Dylan, you need to calm down about the schedule. You're trying to make November schedule and it's August. So we try to be to acknowledge that everyone has a life outside of residency and try to accommodate that.
I will say on average, we publish a schedule about 6 to 7 weeks. This one was a little late and that was my fault, but 6 to 7 weeks before the block starts. So there is, and that's kind of really unheard of. Most places you get it a week or two before.
Yeah. So I don't want to spend all this time talking about the schedule. That can really get really nitty-gritty. But I guess kind of just, we're going to kind of transition into the resident Q&A, but just kind of talk about things I know people ask about a lot. So the first off being salary. So we actually have a pretty generous salary from NYP Queens, and each year we've had a pretty big pay raise. So last year interns were paid like 78,000. This year it was increased to 86,000, and then that's not including a $4,000 cost of living stipend that gets paid like 4 times. Well, in total 4,000, but paid in $1,000 increments throughout the year. In addition to that, Dr. Parikh talked about the lift credits. So we get $1,000 of lift credits twice a year from any hospital sites. So it's useful for getting back after night shift or overnights. You can use it to go to your EMS rotation, to our trauma rotation at Brookdale, to the poison control center when you have those rotations. So it definitely helps in flexibility in terms of that. So yeah, so that's a pretty generous benefit. Things people ask about are, where do residents tend to live? So a lot of people live in Flushing, but the people also, another popular spot is Long Island City, which is where I live. It's kind of the westernmost part of Queens, right across from Manhattan. And people can kind of live along the Southern Line if you're familiar with Queens geography, but like within public transport distance of the hospital. And then a couple of our residents actually do live in Manhattan, which is still a little bit of a harder commute, but still doable. And then Kyle, for some reason, moved to New Jersey this year. So possible, probably not recommended for everyone, but I can understand the allure of the great state of New Jersey.
We once had a resident who lived in Central Jersey, and I would frequently, sometimes in between shifts, find him in the EM house, sleeping in the basement. And I initially thought that it was, because he had such a long commute, which is, I think, part and parcel of it. But then I also realized that he has 5 kids, and I think he just wanted to avoid going home to his 5 kids. But nonetheless, my point is, Alvin Boulahan, yes. My point is that our residents can live, in multiple places. We had people from Connecticut, from New Jersey, from way out east in Long Island. But yeah, the majority of them live in Flushing, Long Island City, Astoria are kind of the big big areas. And it's New York City, so it's very accessible. And now with Lyft tickets, it's very accessible. Some people drive, some people don't. We've got Zach here who basically rides his scooter in. We have people who have motorbikes. Whichever way you want to get to work, it's doable and it's easy. Sorry, keep going, Dylan.
Yeah. So I mean, that's I feel like what people ask about a lot are like, what are the benefits? Where do people live? I mean, I don't have anything else prepared to really talk about, so I've kind of opened up to the medical students if they have any pressing questions they want to open up to the rest of the residents.
Well, yeah, exactly. I just wanted to make sure that the other residents had an opportunity to say anything. I see many of them. I see Faria and Richa on a train going somewhere, and then I don't know. All the residents are at the karaoke bar. So
Yeah, but
what
we
happened to
have
Kyle?
I see Zach, I see Andrew, Callie, David.
I'll just say quickly that our residents love this program so much that Freya and Richa are on a train to Tokyo right now and still wanted to zoom in. So their vacation looks amazing, and I hope they're enjoying themselves.
Hey, how are you?
I
Welcome.
was like, I think they're in Japan, or yeah. Miss you guys. Hope you're having a wonderful time.
Anybody else? Any of the residents want to say anything?
Hi guys, we're here from Flushing.
Nice.
Just wanted to say hello. If you guys have any questions, particularly towards us, we're all second years. My name is Tina.
I'm Rosalina.
Seldon.
We're here to answer any questions you guys have.
And then look at Kyle. Kyle, I just showed us a room full of residents who have probably been drinking, and that's okay, and having a lot of fun, and singing really badly. Okay, so let's do this now. The crux of all the kind of informational stuff is done. Applicants, students, questions for any of us, any of the faculty that presented, any of the residents. Don't be shy. Everyone is having a karaoke moment here to Jay-Z. Might be slightly loud. Okay, gotcha. Okay, we have Rahi Patel.
Hi, thank you so much for holding this session. This was super informative. I'm a fourth year at NeoMed. It's Northeast Ohio Medical University, if you've heard of it. I'd love to get your advice, and of course the residents as well, for advice for an out-of-state applicant who wasn't able to do an away rotation in the area.
So yeah, in terms of our rotations, right, we have 4 sub-Is. I want to say 4 months or 4 or 5. So we typically have about 40 students that have rotated through, but the majority of our applicants that we interview are not students. So we have about 40 students that we do exit interviews with. So they're not actually part of the actual interview season or the interview cycle come November. That's separate, and that's another 200 interviews. So all in all, we interview about 240 people for 9 spots. So if you're out of state and we interview people from California, from Texas, from Florida, from wherever. We have a resident right now from Idaho. We have a resident. We've had residents from Hawaii. So your geographic location, no matter where it is, if we like your application, and you'll receive an interview, and if we like you on interview day, you will be ranked highly, and hopefully you'll match. So whether you were able to do a rotation here or not, and your geography it doesn't really affect your chances of matching here, essentially. I hope that answers your question. And we do have our
Samuel, I think the question was, what do you look for in an application, possibly?
Okay, so now that so I will tell you this. I think as a program director doing this now for 8 years, I will tell you probably the biggest part of your application is your letters of recommendation. Okay, your letters of recommendation are super important. Why? Your SLOEs. because you guys go to do auditions, you guys are working in academic centers with emergency medicine residencies, and when you are there auditioning for a month, you know, your evaluation there goes a long way, because I know, because the people that are writing your evaluations are academic emergency doctors who we put a lot of value and trust in. So that's my first word of advice to all of you is, you know, crush your audition rotations, your sub-Is, show up every day with, you know, a smile on your face, with great work ethic, with, you know, as much grit as possible, roll up your sleeves, see patients, be helpful, read as much as possible, learn as much as possible, be proactive in seeing patients and doing things. That goes a long way, and that gets reflected in your slowies. Medical knowledge, now that you know, step one is pass fail, we honestly are not looking at that as much, you know, because it's pass fail. Obviously, if you fail it, you know, that doesn't also disqualify you altogether, but you know, it's something that we'll talk about maybe during your interview. Step two, definitely we look at. So I would urge you to take step two as soon as possible, because I think a lot of programs will still look to that step two score to offer an interview versus not offer an interview. I will tell you that a lot of programs, including ours, will set some filters in the beginning, where we'll start, and doesn't mean that if you score below the filter, you're not going to get an interview. It just means that the initial applications that we look at, right? Because on day one, when we open our application season, we're looking, you know, pre-pandemic, that was like 1,200 applications, and then it dropped, but now it's slowly going back up again. So last year, you know, on day one, we had 850 applications. By the end of the season, we had about 1,000. So you can't look at 1,000 apps. So there have to be some filters, and sometimes people will set a filtered score of whatever the national average for step two was, or maybe 5 or 10 points below that. And that's kind of how we go through the application season. So we look at your step scores, but again, the most important part of your application is your slowies. And then of course there's everything else. There's your personal statement. There is your hobbies. Please, 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 do not apply and then leave the hobbies section blank, because your hobbies are what make you you, right? What you do in your free time tells us a lot about a person. So every once in a while I will get an applicant with no hobbies, and that doesn't look good. So make sure you have hobbies and then talk about them. And then obviously, you know, the whole rest of your application, it's all looked at, okay? But we put different weights on different parts of it. What am I looking for in a resident? Well, I mean, you know, Dr. Sharma talked about this earlier. The first most important thing, and I hope I can use this word, is don't be a douchebag. Right? Like if you are a douchebag who cannot play well in the sandbox, and you are constantly getting into fights with people and consultants and patients, even worse, then this place is not for you. The parental milestones that I mentioned before have to be part and parcel of who you are, already mastered. So don't be a douchebag. Number two, work ethic. You have to show up to work every day with a smile on your face, rolling up your sleeves, and get ready to provide great you know, patient care, you know, and you're providing it to people who really need it. And you're providing it to our patient population, are patients who just patiently wait to be seen, and they're just happy to be there to get patient care. I've worked in 8 different ERs. Our patients are amazing in the grand scheme of things. Number 3 is probably resilience. You know, residency is hard. It is probably the most 3 challenging years of your life. There are going to be ups and downs. There's going to be times when you fall down. How do you pick yourself up and move through those obstacles and move through those setbacks? And can you bounce back with a smile and learn from your mistakes and move forward? So resilience is another huge part of kind of who we look for. What have been some of the obstacles you've had in your life? That's a common question I'll ask on the interview is, tell me about something that was a big setback for you in your life, or a hard time in your life, and how did you overcome it? So, you know, people will say, well, what about board scores and this and that? You know, all that stuff will teach you. Medical knowledge, patient care, procedural competency, we're going to teach you all that stuff. but it's all that other stuff that I just mentioned, your work ethic, your professionalism, your communication skills, your resilience, that stuff that that we are looking for. Kind of already bring that to the plate.
Okay, Dr. Parikh, there was a question in the chat about letters of recommendation. Like, is there a specific number of slows they want to see? Do you want to see letters from off-service rotations?
So I will tell you the most important rec is a slowey from from a academic center, from an emergency department that has an EM residency. So that's the main slowey. And typically we like, okay, everything was different during COVID. You couldn't, you know, some people didn't even have one, but now I look for two. Okay. And usually that's your home institution plus one away. And really that's all you need. The third one is just superfluous. It's great if you have it, but it doesn't necessarily bump you up, bump you down. Okay, they were able to do a third rotation. Not everybody is able to do a third rotation. So at least two slowies is really optimal, I want to say. Anything more than that is great, but not necessary. We also will see, we hope, and I do look at this a little bit like, okay, your first slowie might have been X, Y, and Z, and your third slowie should hopefully be a little bit better, right? Because you've had now 3 months of sub-Is. So we'll look at that a little bit. I will tell you, O slowies, which are your off-service slowies, that was spawned from COVID, right? When nobody could do, work in the ER, so in the emergency department, et cetera, et cetera. If I'm going to look at an O slowie, I want the off service to be something that is, really pertinent to EM. So if you do like, I'm not saying cardiology, like let's say you just do a cardiology rotation and you have the cardiologist write an O slowie. Okay, great. But also I would prefer something like an ultrasound rotation or so actually that's subspecialty, or an ICU rotation or medical floors or surgical ICU rotation, because that's kind of that's more intense. It's more and getting a good rotation on that service, especially in the a critical care off service rotation, goes a lot farther than, let's say, an O slowie from a general medical floor, etc. So that's O slowie. Then there's the EM subspecialty slowies. If you can, do an ultrasound rotation, do a SIM rotation, do an EM critical care rotation, do a pediatric rotation, do a tox rotation. And if it is a subspecialty within emergency medicine, you can get a subspecialty slowie, a subspecialty in EM slowie, and we'll look at those as well. The general letters that you get written, like, hey, I know this attending for a while, he or she wrote me a great letter. We read them, but they're not standardized, so it doesn't carry as much weight. So that is hopefully I answered your question. I want to say 2 slowies for sure. Some people will actually go to a rotation where there's no residency program, right? But there's definitely an emergency department. They work with ED attendings one-on-one without residents, and you can get one like that as well. But again, it's not weighed as strongly as a slowie from an EM residency program. I hope that answers your question.
Yeah, just what's almost trying to explain is the person writing the slowie should have compared you to other students. And that's kind of hard when you're rotating in a place where the students don't typically rotate.
Are there any questions that I didn't answer from the chat? Who do I contact about doing a sub-I? So Dr. Sheth is our clerkship director, and everything is on the website. So if you want to do a sub-I, those that I think that starts around May and April, where what's it called, VSAS opens up and you apply through Cornell, and we get all the applications, and then we choose our sub-Is. And the selection process is pretty straightforward and streamlined. You submit your application, and I gotta tell you, if you really want to rotate here, there's there is ample opportunity for you to do so, and possibility, the probability is that you will be able to get you in, during one of those 5 months that we offer the sub-I. So Dr. Sheth is the answer, VSAS, and you can look it up on our website. You can also reach out to Lily. And yeah, I think a lot of the residents were saying that many of them are from out of state. So for Rahi, who asked that question, because you're out of state doesn't mean anything. You have a great chance of still matching here and still getting an interview. Anything else?
Yeah, the same thing goes for like elective opportunities. Like we definitely have had students rotate specifically for ultrasound. And I think last year we had someone do a simulation elective. So those are additional opportunities in conjunction with just the regular like EM rotation.
Oh, Dr. Sharma, why did you tell them that? Yes, if you match here, you will have the pleasure of graduating here in 3 years after you come here, and I will read your personal statement, or at least excerpts from it, at graduation with my own ad lib in front of your parents. So be careful.
And then another quick question: does your program consider COMLEX scores in place of USMLE?
Yes, we do. We look at COMLEX score. I think that we are very DO. First of all, we're very DO friendly here. A lot of our core faculty is a DO, including our chief, Dr. Sharma, Dr. Louie, Dr. Simon, Dr. Sheth. We have our fair share of DO faculty and residents. I don't really know what the breakdown is, but it's almost approaching half and half. Okay, so we're very DO friendly here. And we look at COMLEX just like we look at USMLE. Sometimes it's nice to have a DO student have taken USMLE because it helps us standardize. I would say that was more a thing of the past. And over the last couple of years, I've learned what the DO scores are that are good, that are mediocre, and kind of the quartiles. So yes, we do take COMLEX, and we look at it equally as we do USMLE. I actually have like this crazy mathematical formula because I'm brown and my dad just taught me math at a very, very young age. I was doing calculus when I was in 6th grade, and I actually created my own formula to convert a DO for an osteopathic COMLEX score to a USMLE score. So I have a way to kind of standardize everything and have one point of comparison. Can I send slowies later? You can. So if you, right, I think when you first start, you are able to put in, so you can only have up to 4 recommendations, whether they're slowies or letters or this or that. So I would definitely put whatever slowies you have. And if you know that you're rotating or doing a sub-I, let's say in November, and it's not ready for interview season, or December, but you're going to get a slowie at the end of November or December later, leave that, that 4th space blank, because you can always upload it later. And if you've already interviewed at a place, tell the program director or your interviewers that you are doing a future, or you're doing a current rotation, and that there will be a slowie in the future. And then sometimes when it's available, and if you can have your the clerkship director at that place email it directly, or just email the places that you interviewed at and just say, my 4th slowie is now uploaded on ARS. Anything else? Any observership or elective opportunities for US IMGs? So observerships are all done through GME, which is, it's not done through the emergency department. So if you want to do an observership here, it has to go through our main graduate medical office, which again is regulated by Cornell. So it's all through that. In terms of sub-Is, the actual audition rotations, we don't take US IMGs for our sub-Is. However, with that being said, there is a possibility for you to do a rotation basically like January through June. And that Dr. Sheth can talk to you more about. I know she's not here right now, but you can find her information on the website and you can discuss that with her. But we do get foreign medical grads. A lot of them are from a lot of them are from programs that we have relationships with, or contracts with, and generally those residents come with some sort of funding from their school. So it is more difficult, I'm not gonna lie. It's harder for foreign medical grads to do rotations here, but it is definitely possible. I have a few more questions. So I see Yanni.
Yes, how are you guys? My
Good,
name
how
is
are you?
Yannis Skakos. From Astoria, Queens originally, if my name wasn't obvious to that. But so just a question for you regarding kind of like community outreach and things. I know you guys are very active within Queens. I was wondering if the residents do anything to get involved in the community outside of the hospital walls, like any initiatives or things like that?
Nao. Is Nao here? She is, but she might not be present. So Nao is, oh yeah, she's there.
Hi,
Okay.
sorry, I just had to turn my camera off for a second. Yes, we have outreach opportunities. I feel like I commend you for asking that, and it's a great way to stay grounded and stay sane and stay passionate. And relate back to what brought you to medicine in the first place. So some of our most recent opportunities include a bunch of health fairs where we do screenings. We speak to patients about their health. We do blood pressure screening, BMI screening. Some people believe in BMIs, and that's kind of controversial, but either way, we talk about just like nutrition and wellness, and then also advanced directives, and help them. We distribute most forms and living wills and things like that for them to peruse with their family and give them information in that regard. We also do education for the community. So we've done talks for the YWCA, the Metropolitan Deaf Asian Association. They bring us in to talk about various topics, amongst them things like palliative care, psychiatry, for the layperson. I did a talk recently about cognitive decline and aging, and how to maintain your cognitive function. More recently, we're partnering up with the Red Canary Song, which is a grassroots organization that does migrants, sex worker, and massage parlor worker outreach. And we have some opportunities for street outreach, as well as sexual health information, screenings. And yeah, the world is kind of our oyster. I think there's so many different ways to get involved. I take a lot of inspiration from the residents. And, if they come to me with like a project that they'd like to work on, we can like pursue it and try to make the world a slightly better place. So I hope that answers your questions.
No, that was excellent to hear. Thank you very much.
And we have so we also have a messaging platform. It's called Slack. Many of you may have heard of it, but we have a Slack account for the residency. And like on that, for example, we put we have a channel called Community Outreach, and Dr. Yoneda is great at just basically listing all the different opportunities. And residents are busy. We get it. Sometimes on your day off, like all you want to do is literally just sit on the couch and do nothing, and that's okay. But we do have our fair share of resident involvement in many things, whether it's supporting the LGBT community. We do a lot of stuff with the Chinese and the Korean community. All the things that Dr. Yoneda mentioned. And this year, I think the residents are learning a lot through this webinar, because another announcement that I was going to make is this year, actually at graduation, we are going to be giving an award to one resident in each class who does the most in terms of community outreach. I won't tell you what that reward is, but it's a reward nonetheless. So I think that's just gonna hopefully incentivize and we're gonna see even more community outreach in the upcoming future. Plus, we have 3 people. Well, we have 3 people who are 3 faculty members who are in, as part of our global health and our community outreach presence here. And obviously Dr. Yoneda is one of them, who does primarily community outreach, but then Dr. Waswani, who you met earlier as well. And then in terms of global health, we have Dr. Waswani and we have Dr. Tina Yang, who helps plan a lot of our global health projects in Norway, China, etc. Somebody wanted me to share the equation for the Comlex. The answer is no.
Proprietary. No, it's proprietary.
Sorry, it's my own. I essentially copyrighted it, and maybe one day I'll present it at Cord. But for now, I can't share it. And then are there any differences in application process for transitional year applicants? Not every applicant is traditional, right? In that regard, I mean, there are people who wanted to go into ortho and then had a change of heart, wanted to do something completely different, and then wanted to do some surgical subspecialty and then realized the error of their ways and now want to do emergency medicine and don't have slowies, and their application is different, right? They have letters, or maybe during their intern year of whatever they're doing, whether it's a surgical prelim, a medical prelim, a transitional year, you have just letters from your program director, or maybe you have had the I will tell you, if you're a transitional year or surgical or in a medicine prelim, I would highly encourage you to try to get a 2-week rotation in the ED, at least, if not 4 weeks, where you can get the program director and the core faculty of that program to write you a letter. And believe it or not, you can actually do a slowie in that situation. There's just some questions you can't answer, like what was their grade, because you're not doing it for a grade, you're doing it for a rotation. You're not doing a sub-I necessarily. So there are various permutations to all of this. If you are a transitional year resident who doesn't have the opportunity to have slowies, that's okay. And I will also tell you this, if any of you, if let's say I would say by November 15th or so, you haven't received an invitation for an interview, it is perfectly acceptable to shoot me an email, just say, hey, I'm very, very interested. I met you at the webinar. I haven't heard from you regarding an interview. Would you mind please looking at my application? And that will be, and then that will trigger me to look at your application a little bit closer. So please feel free to do that as well. Dr. Sharma has a question.
It's not a question. I just want to make a comment. It's probably not unique to our program, but I don't think any other program values what our current residents think of you on the interview day or while you rotate here. Many people have, how do I say this, taken the wrong route of ignoring the residents and working up and only communicating with an attending. Our residents' opinion matter a lot to us. So just keep that in mind. I'm sure other programs are the same way.
Yes. Every interview day, there is a breakout session where you will meet at least 3 residents. And I typically have 1 resident from each class there. So that's a 40-minute session. Plus you interview with a chief resident. So, and I think Dr. Sharma is right. Any place you interview at where you don't get to talk to or meet the residents, I don't think that's a good sign. So I'm just going to put that out there.
I would say one thing and just chime in. Like I know you guys heard from Parikh and Dr. Sharma about the culture of our program and everything like that, but I feel like it means a lot coming from a resident as well. And I really do value the culture at Queens a lot. I think that, typically when you're in an emergency department, people are always talking about how oh, you're the least respected doctor in the hospital. But at Queens, it's definitely not the case. Our simulation department obviously has a large part of that, but our surgery colleagues are some of our closest friends in the ED, and we have a really good relationship with them. And I think it's really special. We have like attendings who come from like other hospitals who are like, this is crazy. You guys are like friends with them. What the heck? It's like really weird. What's going on? Right. And we rotate up in the SICU. The SICU attendings are all really well read and like, really respect us as doctors. And that goes for the MICU as well. Like we really, really like our MICU attendings up there. The MICU fellows are a lot of times they're residents who used to be IM residents. So there is like a very solid family atmosphere at our hospital. And it's really something to be cherished a lot, especially when you go on away rotations. Like I'm actually rotating right now at Brookdale. And Brookdale is a great hospital, but you still miss your home hospital so much because you're just like, dang, like everyone there is family. So I think that's extremely important when it comes to not only your training, but also your wellness as well. Like we talk about wellness when it comes to like everything in conference, but the day-to-day of being an emergency medicine doctor is extremely stressful, and you're learning a lot, and you're constantly kind of going outside your comfort zone, and having people who you can lean on, having attendings that you can call on a first name basis. I have like every attending's phone number, like personal phone number, and I feel like friends with them. They're not just my like superiors or my bosses, they're like my friends. So I think that is a really strong quality of our program that really should not go unnoticed.
Thank you, David. I second everything you said. Again, I'm not a resident, but I genuinely feel that the residents genuinely feel like they're part of something bigger than themselves here. And like, I'll just give you a prime example. Like, the Chiefs do a great job of putting together this weekly email. And every time a new block starts, it's like, we're losing these two people. This person's going to the MICU. This person's going to the SICU. This person's going to Brookdale. These people are going to China for 2 weeks. We're going to miss you. Don't forget about us, that type of thing. And then when they're back, we give them a big welcome. I don't know if the Chiefs do this year, but I think they do. Our chief residents will go up to the SICU.
Oh, no, it's supposed to be a secret. It's supposed to be a surprise.
Sorry. I didn't know that. Okay, never mind. Never mind. You are well supported, and you feel like you are part of, and I know I started with that, and I'll be honest, it sounds a little cliche. There's a lot of programs out there. You're gonna go on interviews and they're gonna be like, we're a family, and and I'm not saying that they're not, but I just feel like I've been to many different ERs and been part of other families, EM families, and it's extremely palpable here. And I think the residents can attest to that. And at the end of the day, your core faculty just really care about you, and they care about your training, and they care about your wellness. And we teach you emergency medicine, and we do it with a smile. And you'll feel really supported here. I can guarantee you that. All right. Should we have the karaoke people sing us a karaoke song? No, I'm just kidding. All right. Well, look, we're approaching 2 hours here. So I think if there's no more questions, I will say goodbye. Oh, sorry. One last thing. I just want to put a mention out for our blog. I showed you some little bits and pieces of it, but if you want to know even more about about us, just go to our blog. There is a multitude, pages and pages of information there. I like our blog better than the NYPQ website, because the NYPQ website, the official NYP site, is a little bit more rigid, but the blog is a lot more personal. Go to the resident section, see who our residents are, what their hobbies are. We've got silly pictures there. We've got all of our educational stuff, ortho section, ultrasound section, our research and education section, global health section. We have a multitude of videos. Check out our videos. There's a great promotional video that we did in the year of 2020, which is great. That was actually done by one of our residents, not outsourced. It's a great video. We have a hospital tour there. That's a little outdated only because it doesn't include the new sim lab, but watch our tour. Watch the program director welcome talks. There's one for the general residency. There's one for wellness. And then all the webinars that we've ever had, even in prior years, including this one, will be there shortly. So, and then of course, social media. So follow us on Instagram, follow us on Twitter, X, but I know that most of you being the generation that you are, it's mostly Instagram. We're very, very big Instagram users. So follow us on Instagram as well. And get in touch with any of us. Get in touch with any of us if you have any other questions. All of our information is on the website and the blog. Okay? It was a pleasure talking to all of you. Have a great night.
Good night, guys. Take care and good luck. Rooting for you.